I also want to welcome everybody in the morning to the next session about TFCC. And I first want to ask Jeff Ecker to the podium, and we'll talk about the arthroscopic hook test is not pathognomic for a foveal tear of the triangular cartilage. Please, Jeff.
Okay, let's move on to the next speaker, Andrea.
Probably we can follow the discussion across the podium with Jeff, because I'm going to talk about the same, more or less, topic, because you all know about this text, and we better skip on this, but we want to focus on the importance of this test in assessing the competence, which probably doesn't mean that these ligaments are really torn, but they still lacking their mechanical competence, and that is the aim of this study. So the aim of the study was to assess if which of these tests are more reliable to assess the quality of the tear, and especially when you have to diagnose proximals, avulsions, tears, or incompetence of these ligaments. This study was performed on 178 patients that underwent wrist arthroscopy due to chronic wrist pain. We made a selection because we excluded 43 patients, those with positive ulnar variants or with multiple disorders or intraoperative findings of perforation of the TFCC. So quite a group of patients were out of these studies, and 135 patients remained, and they were divided in two groups. And first group A with chronic ulnar-sided wrist pain and positive fovea sign. Group B is a control group, no ulnar-sided wrist complaints, and they underwent surgery before clinical ballotment test to assess DRUJ instability, and then the arthroscopic exploration of radiocappa DRUJ with a 2.7 millimeter scope and dry technique, and we assume that ligament intact on direct visualization of the DRUJ or joint access to the DRUJ was difficult or impossible, equaled a competent DRUJ ligament. If ligament were torn on direct visualization through DRUJ arthroscopy, or fibrovascular tissue at the fovea was present and that required to be debrided, the ligament were incompetent. So that was to support this classification. You all know the patient result underwent a statistical analysis to assess specificity, sensibility. We evaluated likelihood ratio and the statistical significance. So we had 16 cases of class 1, 52 of complete tear, and 12 of class 3 proximal tear. Of those, you see the results of the hook test and trampoline test, and assessing the condition in which the tear was proximal, 64 cases. You see the hook test was positive in 64 cases. The trampoline test showed variable results. And that are the results in the control group. You see all these tests were negative. If we assess the sensibility and specificity, we found that the hook test has 0 sensibility to the distal tears and 100 on class 2 and class 3. Instead, the trampoline test, 75 on the class 1, 78% and 58% on the class 3. So the same results, the results are quite similar if you consider the two classes with proximal and distal tear separately. The likelihood ratio is a condition that gives you an idea if the patient can have this problem. If you have a hook test, he can have 27 times more chances to have a complete tear and 25% chances, more chances to have a proximal tear. So those patients underwent ligamentocapsular repair in class 1 and foveal repair in class 3 and 2, and they show the clinical improvement at 6-month follow-up, as you see in the slide. So at the end of the results of this study, we showed the sensibility of the trampoline test for the intact proximal tears was 75. When the proximal component was lacerated, it was 56. And hook test, it was 0 and 100. Comparing all tests, you see the difference in sensibility, but the hook test was definitely more specific on the definition of the tear, and also the positive likelihood ratio was extremely positive for the hook test. So you all know that the TFCC tears are basically a constellation of which the peripheral tears are only one star, probably the more shining star, but only one approach. This study has a few limitations. Probably a dry arthroscopy may limit our results. Use of 2.7 scope may limit our approach to DRUJ, and also the exclusion of the ulnar plus variant risks, especially because they exclude the coronal tears, which are a special condition in which, due to the tear or the crossing fiber at the foveal level, the DRUJ becomes unstable even if the ligaments are still intact. And in fact, we don't have actual tear, but the ligaments are mechanically incompetent. So we would like to stress that for every TFCC tear, the assessment of foveal insertion should be done routinely, and that's why we developed the concept of the iceberg, because one cannot rely only on radiocarpal joint exploration, but also DRUJ exploration is required in case like this, when you have this kind of tears that require the ligament. Routine use of the hook test may circumvent the needs and the difficulties of DRUJ exploration. Trampoline and hook tests are reliable to make diagnosis of peripheral tear, and compared to trampoline test, hook test shows higher specificity and sensibility to recognize TFC tears, especially when the foveal insertion is lacerated. And the hook test also shows higher specific and sensibility to recognize proximal tests in case in which they are incompetent, as well as the positive likelihood test suggests. Thank you for your attention.
Thank you, Andrea. Question from the podium, from the floor, sorry. No. You have another test too, like ghost sign or push-up needle test? You use it normally, or?
No, actually.
Not, okay. So please, Toshi, talk about new classification of TFCC injuries.
Thank you. Good morning. I would like to talk about a new classification of the TFCC regions, which is, I think, that's a complete classification for this one. There's no conflict on the interest in my talks. TFCC, as you know, that they're going to be a stabilizer of the anacarpal and the DRUJ, and also it acts as a load distributor, and also it allows smooth wrist motion and form rotation. You can see radial ligament arrows from nearly vertical from the foveal region. Then that the Palmer actually classified in his classification in 1989. Then that he classifies the class 1, class 2, and class 1 is the traumatic, class 2 degenerative. This is actually widely used in that in these 30 years. But his description is based on classification was based on the radiocarpal arthroscopic findings. So that he never seen that the ulnar side fracture through the radiocarpal scope. I confirmed with him. Then that also that the 1B tear is normally understandable with the peripheral tear from the distal side. Then that this is a diagnostic view, so that we need diagnostic to see that the deeper region of the triangular fiber cartilage, because this is a three-dimensional structure. Andrea described his classification in 2009, and he actually mentioned about the subclassified 1B tier from the distal, complete, and proximal tier. This is a very useful tier, but still on that subclassification of the 1B tier inside. So that we need to do checking with how is the coincidence of the TFCC regions. So that is why that I did a retrospective study, which is a concept of 230 wrists in a 1 year, 3 months period. Then that I did both radiocarpal and DLJ scope. Male is 123 and the female is 88, so the male is a little bit dominant, right side is a little bit dominant. Then that I found that there are going to be 21 central slit tier. Then there are variations of the tier from the slit tier, flap tier, double transverse slit tier, oblique tier, coronal tier, and bucket handle. It's a closely similar to the meniscal tear in the knee. Then that I found that only one wrist is the distal tear, which was classified as class 1C. Radial tear was found in the fiber, mostly common with the distal radius fracture. Then that 4 is a disc region, 1 is a rim region. Ulnar side tear was found in 52% of most of the cases. Then that the dorsal tear, which was published by a PC Hall in 10 wrists. Then that 2 are isolated dorsal tear, then that 8 wrist was combined injury with dorsal to ulnar. So that ulnar dorsal side was completely torn. Then 2 wrist indicates a palmar tear, which was not published, and then which was not categorized in the palmar TFCC region. 2 wrist has a horizontal tear. Then that 70%, 48 wrist indicates a degenerative TFCC tear, which is the same as a palmar 2 class 2 tear. Then the IUJ findings, 2 had a proximal slit tear to fibrillation. Then that 1 wrist has a radial ligament partial tear. Then the 47 wrist indicates a completely radial aversion, which is 16%. Then that 3 wrist indicates a relaxed radial ligament, which is a good indication for the ulnar shortening. Then that I found that almost 2/3 of the cases had an isolated TFCC region. However, that 1/3 has the double regions. So that you may find that there is a distal tear, but don't stop it. You can do a DLJ scope to find the proximal side tear. With the most popular one is ulnar side and the radial ligament complete tear, which was considered as Andrea's complete tear. So then that 74% has a foveal avulsion or ulnar tear in our series. So palmar classification is very useful still. However, then that Yukio Abe described that there's going to be a variation of the tear. However, that I will provocate the new classification system, which is dividing the distal surface as a class 0 to class 4, class 0 intact, class 1 intradisc, class 2 radial border, class 3 peripheral, which indicates an all peripheral tear of the triangular fiber cartilage in the distal side. Then class 4 is a degenerative tear. Then that according to the DLJ scoping findings, it's going to be a staging. Stage 0 intact, stage 1 slit tear of fibrillation, stage 2 partial tear, stage 3 relaxed radial ligament, which is going to be a shortened ulnar. Then that stage 4 is a complete tear of the radial ligament, should be repaired or reconstructed. It covers all traumatic TFCC regions. So in conclusion, that traumatic region of TFCC was categorized in the class and the staging from the radiocarpal and distal radial joint findings. This can cover all TFCC injuries, and it can be easily understandable to treat the TFCC region. Thank you for your attention.
Thank you, Toshi. Do you have any comments or questions? It's a comprehensive classification.
I think so. I considering about in these 20 years.
Okay, I think we move on, and we're going to have a panel discussion here, so we can get into. I'd like to have Andrea, Martin, Hoya, Jeff, and Huawei come up here. Actually, I would like to ask the panel about the different tests we heard about, the trampoline and the hook test. Is it necessary to perform these tests, and do you rely on them? I want short answers. I want to start with Martin. The trampoline and the hook test. You have the microphone there. No,
Yes, in my case I use both.
but do you use them both?
Yes, of course.
You're also using other tests, push-up needle test?
Sometimes when I have a doubt with the hook test, I use a needle test. It's very practiced to evaluate the proximal component.
Yeah, it just takes 10 seconds to do the hook test and trampoline sign. And also that I do a suction test, which use a suction on the shaver, which can floating up the triangular fiber cartilage. This is actually indirect sign for the foveal region, but I do scope in the DRUJ.
Yeah, I always remember before making the first portal to assess the DRUJ with the patients under anesthesia. If the DRUJ is hyperlax, not unstable, hyperlax, we know endpoint, probably there is something wrong on the radial ligament. They may be on the radial side, ulnar side, and then I scope, and usually I am very good with the hook test. Even if I understand that there are partial lesion, like I can hook the ligaments on the dorsal side, but not on the palmar side. But in my humble technical skills, I cannot make an isolated repair of that ligament alone. So I do this ligament-specific repair with an anchor.
Yes, I use it, but I'm going to use the analogy of the iceberg. When you use the hook and the trampoline test, you're bobbing around like a cork on the ocean. You need to put your aqualung on, and you need to dive into the distal radioulnar joint, and I'm going to tell you that it's not easy. When I first started, I was so confused, I visited Tokyo to watch Toshi do it, and then I watched Andreas do it. And it takes practice. Some of them are hard and you have to feel. And you don't want to be basing your assessment on an indirect evaluation of the anatomy. You have to see the anatomy, you have to feel the anatomy, you have to understand it. And I'm going to take 5 more seconds to say it's only part of the wrist joint. Examine the entire wrist joint and look at the entire wrist joint at the same, because it will impact on the outcome in the long term.
Yes, for me, I will do the 2 tests both. And I also have the same consideration proposed by Jeff Ecker, that the hook test may be not correction with the deep insertion rupture. And maybe I think, personally, the different result from Adri and Jeff, it may be because the depth of the hook you can put. Maybe it is very important for you to put it very deep to touch the deep foveal insertion, and then you can touch the band there. Also, I want to say thankful to Toshi, who taught us how to make the DRU portal, which is very important to assess the deep insertion, I think. Thank you.
Fantastic point.
Yeah.
One person's hook test is not another person's hook test. It depends on the strength of your hook. It depends on its malleable, how strong the hook is. It depends on where you put it. It depends on the laxity of the patient, and it depends on the traction that you've got on the wrist. So it is only one facet, and by itself means nothing. By itself, it means nothing. It's part of a constellation.
Okay, I want to ask you some more questions. We start with Howard. In my understanding, if you have a stable distal radioulnar joint, you probably don't have a foveal detachment, but you may have a capsule detachment. So do we agree that a capsule detachment is usually stable? And if not, you have to tell me, how do you think? And if there is a capsule detachment and a foveal detachment, a complete tear, can you fix both using a foveal reinsertion? You can start forward, Howard.
Thank you. I think if the capsule attachment is also ruptured, we should suture it both. Yeah.
If you look at the anatomy and it's peripheral and the foveal insertion is intact, a peripheral repair will do. If you do an anchor repair or a transosseous repair, you have an increased risk of failure. You'll either get cystic change in the ulna or you'll get late failure and instability over 5 to 7 years. We've followed it up. If the foveal tear is partial, I don't quite know what to do with that, whether or not you do a transosseous repair or you go straight to a palmaris longus graft. If it's gone, it's a palmaris longus arthroscopic tendon graft to reconstruct the fovea with an additional peripheral repair, because you've got to get it all.
Well, in my experience, actually, Jeff, the partial tear are the most, the best tears to repair, because you got part of the ligamentous, which is still there with good vascular supply and so on. So they are not, you don't have that big scar that you usually can find in the large complete tears. And I use a ligament-specific repair, so I put one suture on the palmar radioulnar and another suture on the dorsal radioulnar, and when you pull the suture and you tighten the knots, also the distal part of the tear realigns, so usually I don't put any extra sutures to repair the distal component.
Yeah, that if there is a completed tear, that the foveal repair is essential. So that is why that I do try to do and repair the foveal first, then check with the scope, because we have a scope to check it. And if there is still that hook test or unstable peripheral side, I do put stitches on that capsularly.
Yes, I think so. For me, it's the same. Martin?
Yes, I totally agree with Toshi. I always repair first the proximal component, release the traction, and then scope again what is the tension about the TFCC. If I have doubt and the distal component is, the tear of the distal component is big, I repair also, because for me it's anatomical reconstruction of the both components, proximal component and distal component.
But will a distal component only give you instability?
In some degree. I think that the TFCC is a three-dimensional soft tissue structures inside the ulnar side wrist. If there are going to be a small tear inside the disc, still there are going to be some degrees of the unstable DRUJ. However, that is not completely depending on the patient pain or a patient symptoms. So if the patient has the symptoms, then they're going to be unstable distal side, and we do repair.
Of course, if they don't have symptoms, you don't scope them, so that's why you see the patient. But I think most of the time, if you have a peripheral or capsule detachment, it's mostly more pain than instability, in my experience. What do you think, Andrea?
Yes, the pain is a major complaint in the distal tears, and more than mechanical giveaway or collapse of the joint. And I don't know, any specific question?
No, is it?
I showed you that clinical video at the beginning of my talk of, I call it a wind-off test like that. And if you've got a symptomatic, painful, unstable distal radioulnar joint, that patient will go anywhere you lead them because they want to avoid the instability. You do it slowly so you don't hurt them. So I think that, yes, you can get peripheral tears with a wind-off test with an intact foveal insertion, and they do well with the peripheral repair after they've been debrided.
Okay, I want to have the audience involved here. Do you have any questions about the different tests, the trampoline or the hook test? Are you all happy with it? Do you know all the answers for this? Or there's one question over there.
I have a short question to Andrea. What did you really mean by the impairment of dry arthroscopy and trampoline and hook test? Okay, louder. Andrea,
Yes, please.
you were talking in your presentation about the limitation of dry arthroscopy concerning performance of the trampoline and hook test. What do you mean exactly by that?
Because you see, when you have water inside the joint, the joint is distended, and that it can cause some traction on the peripheral insertion, the capsule insertion of the TFC. So the distal component, the distal part of the TFC is suspended like an hammock, and so it bounces more.
When it's dry?
When it's full up with water. Distended by water, the trampoline is bounces much more than with dry.
But why do you think then the dry arthroscopy is a limitation? I didn't get it.
No, it's not a limitation.
No,
but
okay.
if you're used to see a very energetic bouncing of the TFC, you're not going to see it anymore using dry arthroscopy. Because it's more flat, you see it bounces, but it's not as energetic, can I say, like with.
I am completely positive with you, because you have to be aware of it, and then you have to examine a little bit more, maybe not only 10 seconds, maybe shave a little bit more, release the capsule, remove the synovectomy, and check the hook test again.
When I have a positive trampoline test, so the trampoline is relaxed, what happened, and I don't see any big tear. What happened is that you have some scar on the dorsoperipheral part of the TFC. So you put your probe and also the shaver, it goes very easily between the fiber of the ligament, and that's the difference.
Okay, let's move on to our next topic here, because usually when I see a patient, they do bring an MRI. So my question is, do you always go for an MRI before you operate the patient, and does the result of an MRI change your decision making when you see the patient before you operate? Martin, you can start.
It's a good question. For me, the more important is the history clinic of the patient and the semiology that I can prove when I do the test. But in my country, it's necessary to solicit an MRI or have an arthro MRI to approve to the operation to do it.
I don't do it. Only if I have other questions, what I want to have, I don't know, I suspect for Kienberg or whatever, but otherwise I don't do it. A lot of patients coming with it, but I don't do it.
My country is a little bit situation different, because an MRI is much cheaper. So that is why that I do an MRI for any screening on the patient. Then that if I found any pain, if tear, then that I do also still do an arthrogram. Then that there going to be an MRI has an advantage for seeing the foveal region very well. Arthrogram seeing the peripheral side, so that both are actually that's co-working within the TFCC regions. Then I do scope.
So with a negative MRI, you still with scope. So scope is the gold standard.
Yeah, that's true.
I agree. Scope is the gold standard. I use MRI to exclude concomitant injuries, like I don't know, a Kienberg or something like that. And I'm more. I favor much more that the patient come to visit me with plain X-rays. They're more important to me than MRI.
Yes, I do an MRI on all cases because I can get them, and I do them to exclude other pathology in the wrist. They're only accurate in perhaps 50 to 60% of cases. A negative MRI scan doesn't exclude pathology in the wrist. In fact, it's a real mind block to a lot of people. They see a negative MRI and they say there's nothing wrong. I can tell you now that's really a long way from the truth. And if there's any ECU instability, I'll do an ultrasound myself in my own room and compare both sides, because what I want to be absolutely certain on, to the best of my ability, is that I'm operating on the right thing and that patient is going to do well. Okay.
Yes, I also agree with that the scope is a golden standard, but in our medical center, we will perform MRI evaluation for every patient, and I think the MRI is very useful for the type 1 injury and maybe the type 2 injury. You can see there is some degeneration from the MRI image, and for the type 1 injury, maybe sometimes there will be some negative result, I think.
Okay, once again, very short. If in the MRI you have a lesion, is this the indication for scoping, or is the clinic the most important for the scoping?
The clinic is the most important.
The whole lot, clinical examination, the MRI is just one piece, and if you rely on that, you're going to make errors.
I agree, clinical.
Yeah, I completely agree with that. Clinical is very important.
Yes, we try to treat patients and not study.
Jan mentioned before they're coming because they have ulnar-sided wrist pain, and this is why we are scoping. If we are scoping for another reason, that means a ganglion or whatever on the radial side, and we find a partial TFCC lesion, do we treat it or do we leave it because there is no ulnar-sided wrist pain? What you are doing?
We want to filter the TFCC for that kind of patients.
You don't treat anything that's not hurting, because you may make it worse, but I will throw one word of caution out there, that the TFCC is part of the wrist, and I would advise the patient, look, I found this lesion, it's not symptomatic, but it may be a problem, because I can assure you that up to 30% of significant TFCC injuries have dynamic scapholunate instability, and it's more important to do a really accurate examination of the wrist arthroscopically, record it and have it there when the patient comes back so you can press the button.
I agree, I wouldn't treat.
Yeah, if the patient was in a general anesthetic condition, I just leave it because there's no pain. If I do a local or brachial plexus anesthesia, then I ask the patient, do you have any pain on the other side? If it records the patient the pain, then that I do repair.
Yes, I agree with all. Depend on the patient if he has pain or no. But in the case of the volar ganglion, if I discover an TFCC, probably repair, because there are papers that establish that a close relationship with the recurrence of the volar ganglion and the rupture of the TFCC.
Okay, do you have more questions from the floor? We have then, I think we should move on to the most important talk today, this morning. This is to remind all of you out there that EVAS, European Wrist Arthroscopy Society, we do have a junior grant, and we give some financial support for one surgeon to travel around the world and meet people, meet some of the masters. And Marianne won last year. And Marianne, you're going to give a report.
Thank you very much. Dear audience, dear colleagues, I am really happy to be here today to report to you my experience during this one-year fellowship. And I really want to thank you, all the EWAS members and the board, to help us, to support us, and to give us the opportunity to live this kind of experience, because it is really about one life experience. So my name is Marion Burnier. I am from Lyon. I work with Professor Herzberg, and I also would like to thank him for supporting me in this project and to push me to visit and to learn more and more. For traveling fellowship, I think it is important to ask you these 4 questions. First, why? What is your purpose? It is, your goal, it is your private situation, you can have different purposes. Then when? I was very happy to spend this 1-year traveling fellowship after performing my fellow training, because I think once you have trained by your own, you may have some more questions, more experience, so it was really useful. Then how long do you want to live? How long do you want to travel? Maybe my advice will be at least 3 months, because you can really see the life of the unit, share with people, meet people, and it's very interesting. And then where? Everyone can choose where. As you can see during this meeting, there is a lot of great people, great faculty, a lot of things to learn all around the world. Decided to visit 3 different people. I spent 3 months in Hong Kong with Dr. PCO, then 3 months in New York with Dr. Scott Wolf, and finally 6 months at Mayo Clinic. So first, let's move to Hong Kong. The Prince of Wales Hospital is a government teaching hospital. As you can see, it's far from Hong Kong Island. He's in the New Territories. There is a trauma center, then a hand emergency center, and they are working with the Chinese University of Hong Kong. Dr. Pak Chung-ho, that everyone knows, is the chief of the unit of the Department of Orthopedic and Traumatology, and as we know, he's the pioneer in wrist arthroscopy since 1997. And he loved teaching, and as you know, and I encourage you to go to this wonderful meeting he organized every year with such an amazing faculty in December. So my everyday life in Hong Kong, it was really great because I was able to follow all the surgeons, to follow Dr. Ho and all his wonderful team, Dr. Mack, that I thank you, and Jeffrey and Dr. Che and all of them. So there was a ground room at least twice per week where we learn a lot because they are very precise in their clinical examination. And they like to teach from the resident to the fellow, etc. Then I was able to go to the OR, and of course I learned a lot about, I learned a lot about Walland procedure, wrist arthroscopy, and we were able to make some scientific research, like about partial wrist fusion. The paper will be submitted soon. But also a nice study about arthroscopic TFCC repair, perifoveal repair. And because of these 3 wonderful months, I think we developed true relation, true friendship relation, and we may be able to continue this partnership. Then in February, I've been to New York, the cold winter in New York. Welcome. And I would like to thank Dr. Wolf and his team for his enthusiasm and all I've learned. I was at the Hospital of Special Surgery. As you can see, it's in the Upper East Side. It's nearby the East Rivers. It's a hospital dedicated to orthopedics and rheumatology and sports medicine, very specialized. I think you all know Dr. Scott Wolf for how he learned to us about wrist biomechanics and especially the dart throwing motion, but also the peripheral nerve injuries. I was lucky enough to go with them in the OR to follow some surgeries, but also I had the amazing opportunity to work with them on wrist biomechanical study. I invited you to follow the presentation this afternoon at the FESSH meeting. It was a study about comparison of 3 different techniques of scapholunate ligament reconstruction. But we also made a clinical series about peripheral nerves, about the anterior anteroceus nerve syndrome. Then finally, I've been to the Mayo Clinic in Rochester during the summertime. And as we know that the needs of the patients come first at Mayo. And it's really a role that the Mayo brothers show and teach to everyone, and I think there is 3 main pillars of this amazing institution. It's education, clinical practice, and research. Everyone who has been to Mayo knows that, and this is really true. And you just have to have a look to an aerial view of the Mayo. As you can see, you have the anatomical lab very close to the biomechanical lab and very close to the hospital. So you are in the perfect condition to work, to learn, to teach, to perform biomechanical studies. I was lucky enough to work with all these different amazing teachers and surgeons. I was with Dr. El Hassan and Dr. Kakar for the wrist surgery, and with Dr. O'Driscoll and Dr. Sanchez Sotelo for the elbow surgery. Considering the wrist surgery, we worked on dry wrist arthroscopy, and we also work on a biomechanical analysis about proximal hamate graft to reconstruct the proximal pole of the scaphoid that we presented 2 days ago here at the FESSH meeting. And finally, we also made some studies on elbow surgery, on arthroscopy, and ulnar allograft prosthesis composite. So please, one more time, I would like to thank everyone, and I would like to tell you that when I applied for this grant, I was hoping, of course, to improve my skills, to learn, to make research. But I'm glad that I made it, but most important, I already had a one-life experience. I met wonderful people, met new friends. So please, let's have a try. Thank you.
Thank you, Marianne. I think you represent a great candidate and the winner of the award or the prize. We think it's fantastic what you've done. And I want to encourage you out there to apply for the junior grant. You have to send an application to the Secretary General of IVAS. You find this on the website. With this, we want to conclude the session. Thanks a lot for coming.